For the welcome to you all for the
recording in progress.
Okay. Right. A warm welcome to everyone to the first of the lunchtime lectures that will be held weekly throughout February to celebrate the life, work and legacy of Dr. Julian Tudor Hart, who was a passionate defender of the NHS and inventor of the inverse care law. So the first lecture, today's lecture, will be given by Dr. Brian Gibbons and is titled Local Reflections, Local Deeds. So Dr. Brian Gibbons was raised in County Roscommon, Ireland, and moved to Yorkshire in 1976 to train as a general medical practitioner in Calderdale. He worked as a general practitioner in the Avon group practice from 1980 to 1999 in Glyncorrwg, and also worked as a GP in partnership with Julian Hart at Glyncorrwg in the Avon Valley near Port Talbot. Throughout his time as a GP, Brian was a member of the British Medical Association, the Socialist Health Association, and the Medical Practitioners Union Unite, and is a fellow of the Royal College of General Practitioners. Brian served for 12 years on the National Assembly for Wales after being elected in 1999 to represent the Aberafon constituency, serving as Health Minister and the Local Government Minister. In his own words, Brian is passionately committed to the National Health Service as a public service. So please, Brian, welcome.
Thank you very much indeed, Carmen, for the introduction. And I would like to thank the RISW for putting on these lectures. And it's a great privilege for me to be in the first of the four lectures to commemorate and remember the massive contribution that Julian Tudor Hart has made to the practice and philosophy of healthcare, not just here in Wales, not just in the United Kingdom.
We've lost audio. You're on mute, Brian.
Yeah, I'm particularly pleased to see Julian's wife, Mary, here. Kat Edwards, who was part of the research team at Glyncorrwg, and a number of other people from Glyncorrwg, some of whom seem to be in the middle of eating their lunch. So apologies to them as well. If I may start, I feel a bit like the launch team in Cape Canaveral, wondering whether the technology will work with this, because we've got a couple of changes, but let's see whether or not we can at least get to the countdown. Okay, so can everybody hear me and see the screen?
Yes.
Yeah, thanks very much indeed. When I started thinking about what I'd say in this talk, I had a look on to see what the Royal Institution itself, Royal Institution South Wales, sort of said about itself, and I was interested that the founding fathers, and I guess they were all founding fathers back in those days, but the founding fathers were interested in matters philosophical, the arts and science, and that the people involved were very much hand-on practitioners, in other words, business people, industrialists, and so forth. And while I'm sure that Julian Hart wouldn't have shared the worldview of these businessmen and industrialists, nonetheless, I think that Julian and the founding fathers of the RISW were very much people of a similar mold, as I say, even if they didn't share the same views. I say that because, as well as being a great family man, Julian Hart typified his life by being a practitioner, a philosopher, a scientist, and an artist. And in line with the spirit of today's talk, he worked in Glyncorrwg in the Upper Avon Valley in the hinterland of Swansea. And this indeed is a picture that Julian himself painted of Glyncorrwg. And you can see the South Pit in Glyncorrwg, which was the last working colliery in the Upper Avon Valley, the village of Glyncorrwg. And here is where Julian and Mary and their family lived in Glyncorrwg, right in the heart of the village. And maybe just somewhere down around here, when Julian first came to work in Glyncorrwg, they had a souped up shed from which he began to practice medicine, though he later moved to a purpose-built health centre in Glyncorrwg, which was one of the first health centres provided in Wales. When I say that Julian was a practitioner, he worked as a full-time general practitioner in one of the areas in the United Kingdom that the heaviest workload. He did the morning surgeries, the evening surgeries. He did the night visits. He was on call at the weekend. He worked one rota in 3, one rota in 2, one rota in 1. In other words, constantly on duty. And a working week regularly constituted 70 to 100 hours, sometimes even more, providing a full range of comprehensive and innovative medical care. But as well as being a full-time GP, Julian was also a community activist. And for people coming from Swansea to the Avon Valley, you'll come up by the Avon Forest Park and Avon Argyll Country Park, where you'll find the South Wales Miners Museum. The South Wales Miners Museum, along with local members of the community, it was very much a project that Julian Hart led on. His original idea was that when the South Pit closed in Glyncorrwg, that the museum would be based there, anticipating pretty much what happened in Big Pit in Blaenavon, but for a number of reasons, that wasn't possible. But the current Miners Museum of South Wales is based in Avon Argyll, and certainly well worth a visit for 2 or 3 hours if you're visiting the Avon Valley. If you come into the village of Glyncorrwg, you will be struck by the series of ponds that are visible as you come into the village. These are not natural ponds, but were again the result of a campaign that Julian was very much to the forefront in. And indeed, with that, those ponds and the Glyncorrwg Ponds Cooperative became the hook by which the Glyncorrwg Mountain Biking Centre was established on the edges of the village. And indeed, the Mountain Biking Centre in Glyncorrwg is now one of the leading centres for mountain biking in South Wales. But as well as being a full-time GP, as well as being a full-time community activist, Julian was also a politician. He served on Glyncorrwg Urban District Council for many years up until the time of its abolition in the mid-1970s. And he stood for Parliament on 2 or 3 occasions. And as well as that, he was an artist and a craftsman. And the picture that you see here as well is one of Julian's own pictures. You can see it's a little bit in the past because you can see the GP out on foot doing home visits. This is Julian himself knocking on a door. Life is going on as normal. It's got a bit of the Coronation Street about it with the animals running around in the background. And the political message, Pentrediwaith, the village of the unemployed, reflecting the social and economic challenges that Glyncorrwg as a village faced. So this picture in many respects encompasses the totality of Julian's life as a practitioner. And indeed, I think one of the most remarkable pieces of work he did was a for scale model of HMS Beagle, the boat which Darwin used to undertake his exploration and discoveries in the South Atlantic from whatever 1832 to 1835. As I say, this is a scale model. I apologize for the quality of the picture, but you can see along here are actually little models of people. And not only is the ship to scale, but each of these models are to scale, and they represent each of the crew members of the HMS Beagle, from its captain to its surgeon. And indeed, there is a little cabin boy there playing an accordion, if we could see the details good enough. So it is a remarkable achievement, and it just goes to the sheer versatility and the broad agenda that Julian lived his life. But Julian was able to step back and not just deal with the day-to-day matters. He was able to see the bigger picture. And indeed, I think it would be fair to say that probably he was involved in drawing the bigger picture as well as seeing it. He contributed a massive amount of work to the philosophy of healthcare in Britain through the book, The Political Economy of Healthcare. He wrote about what doctors should be doing and how they should do it. He wrote articles for the learned journals. He wrote articles for the Socialist Health Association, which he was a very active member and a life president for very many years. And you will actually notice here on the cover of Feasible Socialism, Julian Tudor Hart, with illustrations by the authors. There's not many books of philosophy in which the author of the book also illustrates his own work with his own hand. And here as well, Marxism Today, Julian, for a number of years, was on the editorial board of Marxism Today, at a time when Marxism Today was a very serious platform for debate on the socialist and left agenda in the United Kingdom. But I don't think that Julian's philosophy just came from his life experience. He was a disciplined scientist as well. He is best known, as we heard from Carmen in the introduction, for the inverse care law. And that was initially published in The Lancet in February 1971. And indeed, originally it was hoped that these lectures would have taken place last year to commemorate the 50th anniversary of the publication of the inverse care law. But obviously with COVID and so on, that wasn't possible. The inverse care law is widely cited throughout the medical literature. And it may be just worthwhile just taking a brief look at the summary of the inverse care law. It is worth pointing out that the inverse care law is more of a review of the literature rather than empirical research in its own right. But nonetheless, it is a very, very important insight into the way that healthcare in particular, but public services in general, operate. The inverse care law states the availability of good medical care tends to vary inversely with the need for it in the population served. This inverse care law operates more completely when medical care is most exposed to market forces, and less so where such exposure is reduced. The market distribution of medical care is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. In other words, the inverse care law was saying that the quality of the service provided tended to be worse where the need was greatest, and the quality of care was best where the need was least. And the factors that were leading to this maldistribution of medical resources was the operation of the market. And unless we recognized that the market was the main factor behind the maldistribution of medical resources, then we would never be able to match proper healthcare need with the quality of the service that was needed. The inverse care law, as I say, was an important insight into the way healthcare was delivered. But of course, if we look around us, the inverse care law operates virtually in all public services, and indeed a large part of services that all of us use on an everyday basis. Whether we look at education, whether we look at housing, whether we look at the quality of the built environment, the quality tends to be worse where the need is greatest. And I think that is an enduring insight which we always need to hold on to. But as well as coming to conclusion from reviewing the literature in the inverse care law, Julian did a lot of empirical field work in a wide range of areas of medical study, particularly starting with the comprehensive screening for blood pressure in the Glyncorrwg community, the first time that that was done. But equally, he went on to study risk factors for heart disease. He worked with the Medical Research Council in its community unit to do research on the causes of cancer, investigating whether changes in salt diet would affect blood pressure, or whether or not the use of anticoagulants in the community could prevent heart attacks from occurring in the first instance. So not only was Julian's approach to healthcare based on his own personal experience, but it was also based on a rigorous application of the scientific method. And it was all done here in the health centre in Glyncorrwg. This is, if you like, the modern updated version of the health centre. Julian started in a quasi-tin shed, moved to the first health centre in Glyncorrwg, and this is the current model. And as you can see, it's a relatively humble building by anybody's estimation. The medical services were provided at the back of the building, and towards the front of the building is where Mary Hart, Kath Edwards, and the rest of the research team did most of their work. And as I say, the building still stands. Towards the end of 2017, South Wales Miners Museum, which Julian was one of the founders of, decided to try and collect some of Julian's memories for the record, and two members of the staff at the time, Eamon Scullion and Will Sims, undertook a series of recordings with Julian. And I think that that is particularly appropriate, not least because one of the last visits as an activist that Julian undertook to the Avon Valley was at the South Wales Miners Museum in October 2016. And we can see Julian here with, most people will recognize Michael Sheen and Meyer Boast, who was chair of the Board of Trustees of the museum, and Julian and Meyer's father were leading lights in getting the museum established in the first place. So we are very grateful to Eamon and Will and to the current directors of the South Wales Miners Museum for collecting these interviews and giving their permission for their use today. So just to briefly give some context to what the interviews will be covering, they run for about 25 to 29 minutes. They'll deal with Julian's family background, his initial exposure to general practice, and probably to South Wales. It'll give some recollections of Julian's life as a student, but also covering the period at the start of the National Health Service. And he makes the point that while the National Health Service seems to be a little bit of a British religion in current times, that starting the health service back in the 1940s, not everybody was on the same side. And I think that we do need to bear that in mind, even in the current day, that there are those who don't really subscribe to the principles that underpin our National Health Service. We'll hear of Julian's early ambitions and some unrealistic visions he had about being a GP, and some recollections about his medical training. And he says what his recollections were as to what general practice was really like in those years, the 50s and 60s going into the 70s, particularly in a mining area such as South Wales. We hear about his move from, if you like, straightforward general practice towards research and epidemiology, and the influences on his thinking by people such as Richard Dahl, Archie Cochrane, and Austin Bradford Hill. Richard Dahl and Austin Bradford Hill are best known as being the researchers who made the link between smoking and lung cancer and heart disease, probably the single biggest breakthrough in our understanding of the causation of ill health in the second half of the 20th century. Archie Cochrane's name lives on in an international collaborative organization which researches effective medical care and evidence-based medicine. Both Richard Dahl and Archie Cochrane, certainly in those years, were men on the left. But Austin Bradford Hill was a conservative, very much a Tory view of the world. But he was a key innovator in medical statistics and the development of the randomized control medical trials. And I think it's a characteristic of Julian. So even though Austin Bradford Hill for certain wouldn't have shared Julian's view of the world, Julian respected Austin Bradford Hill's commitment to the scientific method. And indeed, in many instances, Julian would have more affinity with political enemies who stuck to the scientific method than those who adopted a left-wing position purely for populist or opportunist reasons. And then finally, we hear about Julian's life with Mary and the research team working in Glyncorrwg, and how life in a mining village affected his decision to continue to work and live there rather than departing for the ivory towers of academia. And after all of that, hopefully we might have a few minutes for questions and comments. So if I may then, Carmen, try and get the interview up and running.
Yes, of course, please do.
So here we go.
My father
Can people hear that?
I think, Brian, you may need to remove the slideshow first.
Okay. Is that working?
He was very well trained in orthopedic surgery, and that was his main interest.
Can't hear it, Brian.
Okay.
We had audio, but not video.
Okay.
My father,
Is that working? Is that working?
Yes, yes.
Yes, but can it be louder, please?
Incidentally, the GP, he was very well trained in orthopedic surgery. That was his main interest. I don't think he really intended to be a GP. He really wanted to be an orthopedic surgeon. There was a dispute, which at the time was famous, between the coal miners, tin plate workers, steel workers incidentally, who all jointly operated these many NHS schemes. They all thought the NHS was born internationally. I think people would have said that it was if I had been there. Tredegar gets a little bit more credit than it deserves proportionally, because that was a nice place, you know. Anyhow, the miners and tin plate workers wanted the fund, their system, to employ some full-time, fully trained eye surgeon, ear, nose and throat surgeon, and I can't remember, there was a third one, I can't remember who it was. They weren't satisfied that the GPs could satisfactorily undertake that sort of work. The GPs, these people would have to be paid, and so that was part of the budget that might otherwise have gone to the GPs. It was going to be subtracted and instead would go to the employment of these full-time consultants. The BMA was full not only of other GPs who were terrified of the same thing happening anywhere else, but it was also full of consultants who hated the idea of anybody being salaried to do eye surgery or ENT surgery. So the BMA paid for the dispute. The miners went, the GPs went on strike, withdrew from the scheme, and the loss of income was made up by the BMA, so it could go on more or less indefinitely. The miners' union and the tin plate workers advertised for doctors to come and help them. Latex or redneck. Hard to tell which, really. So my dad, being an active member of the Communist Party, went down and for about 18 months he worked there. Well, I thought this is admirable. So as my father and mother were divorced, which wasn't as common in those days as it is now, I wanted to be more like other children who've got fathers living in their home. So I rather idealized my father. I think he wasn't really a very efficient father. That was a noble thing to do. And then as soon as that dispute was over, it was settled in the end. Time to say even one. Charles Hill was the guy in charge of the BMA at the time, these negotiations, who went on to become the radio doctor and a vicious opponent of the NHS. So then my dad went off to Spain to be a surgeon, mainly orthopedic traumatic surgeon in the Spanish Civil War. which I thought was even more noble. I joined the Communist Party myself as soon as I was old enough to join. We didn't. When the health service arrived, I was a student then. There was a division among the students for and against the NHS. Almost unanimously, the established teaching hospital consultants were very hostile to the NHS, told us this would be the end of good clinical medicine and so on and so on. My impression was that most of the students agreed with them. But when I talked to my colleagues my age now, that's not their memory. They think they were all for it. I'm not quite sure. It was really dramatic that within 10 years, overwhelmingly British GPs were grateful for having a health service and wouldn't seriously think about ever going back to private practice or to fee-pay practice. I think what actually happened probably is that most of them kept silent and were careful not to upset their teachers because their future was in their hands, whether they get them jobs or not. And I think I and my fellow comrades isolated ourselves because we were militant. We wanted everybody to stick up with the politics. So I had the future clearly mapped out for me. I wanted to be a doctor because that way I would be a useful person rather than pretty useless, which is what I thought I would have been. And the place you should do it was a coal mining village, and there you could become a tribune of the people and that stuff. So my intention always was to be a miner's GP. I didn't want to be a specialist. It took me about 10 years to understand that approach was about 90% wrong, about 10% right. I turned from spending an awful lot of time on political work to doing more and more, getting more and more interested in getting back to research. I've been in practice in London for 5 years. I left my practice and I went into epidemiological research, first with Richard Dole in London, who became very, very famous, and came to South Wales with Archie Cochrane, who also is very famous, deservedly. Studying illness, health and illness in whole populations. And the principal teacher at the London School of Hygiene, my immediate tutor was Richard Dole, but the person who influenced me most was that's right, yeah. Austin Bradford Hill. He wrote the first textbook of statistics for doctors. That was about 1937, 38, something like that. Conservative in politics, but a real revolutionary in his. If you follow through his ideas about medical science, he was very keen on studies in populations, and they had to be whole populations. They had to be, you had to count everyone. You had to update your population every week to make sure that you've got everyone, that everybody, you got as close to 100% registration and participation as it was possible to get. And I thought, wow, you got it made, because that's how general practice is organized. You've got the list. And in a mining village, that will be a geographical list. One doctor, one village, one village, one bit, one doctor. You'll know everybody. You not only know them because they're patients, you know them because you go out for a drink from there they are. Or you have an allotment. You work with them in the allotments and so on. I knew already that from working with Cochrane at the New Microbiology Research Unit, I worked in another and met Mary there, that if you've got enough cross-sectional studies, that can somehow, you add all these cross-sections together and you'll get longitude. You don't. I think we need research going on by GPs in general practices. They probably need more and more to cross generations, so you won't even be able to complete your study. You have to hand it on to a successor, and you have to hope you could find a successor who's that interested in research. I can do it. I have no successor for that part of my work, but I still think that this is an enormous opportunity we've got in the NHS. They don't have it in America. They can't get their heads around the idea that patients could not be customers. They don't know the striking thing about practice as it was in 1961. I've done locums in the Rotterdam. The MRC are very bad players. So working as a trainee epidemiologist, I was so poor actually that I was lodging in Barry, and for a while I thought, well, I might be able to live on digging up, getting limpets off the rocks there and digging up some cockles in the sand. Well, digging up the cockles in the sand, if you do that in Barry, about 3 inches down, the sand is black. It's the sort of pre-First World War layer of sand. There ain't no cockles in it. And as for limpets, I'm told that they are edible, and that I think I probably boiled them too long. I thought the longer you boil them, the less like rubber they may be. But anyway, they were like rubber. So that scheme fell through. But I was really short of money. So whenever I had time off, I did locums in rubber. And 60 patients to see in the morning surgery, 25 home visits, another 60 patients to see in the evening surgery. So there was no question at all of doing anything on it. I mean, the reason the time was limited was because, well, there were these 25 people to visit at home. So you have to stop. And you find what's happening is that your patients, although you may take twice as long seeing them as the previous guy, it's still only about 6 or 7 minutes instead of being 2 minutes. So really what you did was to meet expectations, plus a little bit more, not quite so awful as what you were used to. And every day you try to find perhaps 1 or possibly 2 patients where you could really make a difference to somebody, where what was happening to them or not being done for them was so awful that you couldn't let it go on any longer. I came across a woman in her early 20s who was already, her heart was beating irregularly because of her untreated paratuberculosis, hyperactive childhood. It was disgraceful. She'd been referred to, the doctor had made diagnosis for it, but she'd been referred to end up in a hospital. About a year to wait. So, you see, there's nothing new about waiting lists and stuff. Well, after all, if you're in the book, you can see how to treat it. You don't always have to be a specialist to treat things.
We've lost the sound. Oh, it's
But
better.
you get away with it because you can get away with just about anything for a short time. It's very rarely that you pick up anything. Perhaps 1-2% of them, something like that. So that means that 98% of them you've done nothing. Well, sorry, that's how medicine really is. Picking up 2% or something is very, very important. People do, it's thinking that general practice, as people did in those days, in the 60s, they still thought of general practice as definitely an inferior, it was a sort of dustbin for doctors who failed. You were taught entirely by consultants. The aim was to produce consultants. They taught you how to be a consultant. So if you failed in all those three things, then you were a GP. I remember asking one of the more approachable teachers, it's St. George's Hospital, and it was at Hyde Park Corner. Sir, you've just shown us this man, and your diagnosis depended mainly on these various blood tests. But I'm going to be a GP. How would I do that? I know how to take the blood all right, but I don't know how. But we had a formal training in pathology, laboratory pathology. They taught us to do red cell counts and white cell counts and so on. No GPs do red cell counts and white cell counts themselves. It would take you half the morning. And anyway, you're not doing enough of them often enough to have the skill. So anyway, I said, what do you say, Claire? It's interesting. Yes, that's an interesting question, Hart. I don't know. No, I think probably if you rang up a pathologist at the local hospital and asked him if he'd mind if you give him the bloods, he'd probably do them for you. I asked him, try that. But he never even thought about it. And he's teaching all of us, and at least half the people he was teaching were going to be GPs. And yet he never told us how to get these things done. So, I mean, it's completely different now. It's fantastic the way medical students talk now compared with those days, but it really was barbarism. Actually, posts in mining areas were quite sought after. Not just any old post. You wanted to get in as a principal. The common thing was that you had an advert in the British Medical Journal, assistant with view required. With view meant that there was a prospect of becoming a partner, but there's nothing in writing to commit them to how many decades you'd have to wait before you were a partner. Terrible. So suddenly, coal mining practices became very unpopular with the doctors. Twice as much work, very high consultation rates, not only from the men, but from the wives and the children. They'd always had free care. There was never a co-payment. So there was nothing to stop people going to doctors. I think that's great. I mean, people are inhibited from going to doctors for all sorts of other reasons than money. Just deleting the money is very, very, very important. And I think particularly important because it stops a corrupting effect on the doctors. They don't feel pressure to do something so that they visibly are giving you something back for the money that you're paying to see them. It's a very unhealthy thing to. You need to be able to say the best thing to do with you with that allowance. So I knew what a big figure a doctor was in a mining village. No matter what the doctor thought, if they had very high status and a great deal of influence and authority. I thought, well, you know, this is just what I want to do. But I didn't any longer want to use it for shoving people in the direction I thought they ought to go. I thought I could do much more applying the Bradford Hill philosophy to research. You include everyone. That means you include Tories and fascists and people who never think about the world at all, alcoholics, drug addicts, child abusers, everything, everyone. Got to include them all. And that was the way to be a good GP anyway. You had to learn how to retain I don't know, the words don't exist really because we all have to pretend to be not to be judgmental. Well, you mustn't be judgmental in the sense that you set yourself up like a judge with your patients as though they're on trial, but of course you can't make moral judgments. How can any doctor avoid having opinions about the patients? But the truth is that the more you see of patients, the more you see how weird people are. You are aware of most of your own weirdness, but of course, like most people, you think it's only you that's weird. Well, I think you really learn, if you learn anything at all, it's really defining the limits of what's a normal person is impossible. People are what they are, and it changes from one century to another, or actually nowadays in much less time than that. So this very democratizing idea, which for some reason or other for Austin Bradford Hill stopped politics as soon as the word politics appeared, he became a Tory. But actually, in his work, I think he was a great socialist. And he taught us about the immense importance of valid data. He taught us all the ways in which data gets corrupted by, for example, we did a study once which we didn't publish, but we looked for all the fat people in the practice, everyone. Really seriously fat people who can't get through doors, who can't fly in an aeroplane because there'll be a seat up their bum. Those people are not included in most population studies. Quite obviously that they're hidden away, they're not in circulation. A really good GP who has a proactive interest in his population, you know about these people. Well, we found there were about 3 times as many monstrously fat people as the best population study that had been done from a guy working at
Oh, it's all right, I'll come back on.
happens next, what happens to the children and grandchildren and so on. And our connection with the village now is that we go to the funerals, and I see people go to funerals, which is not everybody, but it's an awful lot of people for Valley funerals compared even with Port Talbot funerals. We pack out Crown, normally full up, very nearly everybody. And we did contemplate leaving in Bitter closed 1970. Everybody thought the village would sort of collapse immediately afterwards. Well, it didn't. Everybody in every colliery village thought the moment you close a pit, everything will collapse. It's not true. But everything does collapse. It's just that it doesn't happen that fast. For a short time, actually, people are in their oars because, you know, they're not having to go underground. But the effects, the social effects of the Thatcher closing down of the industry were absolutely catastrophic and awful. And anybody who asks the question, you know, did you notice any change? Of course we noticed a change. We noticed the kids becoming drug addicts and the grandparents hating the grandchildren, people being ashamed of themselves. That it was it's like asking people in Upper Van, did it make any difference that all your kids were killed? You mustn't ask the question. Anyway, so at that time, as the impact was beginning, and we realized nobody really in the long run has much of a future here. You've got to have work. Everything revolves around work, and so it should. And then along came the first miners' strike, the 1973 strike. And suddenly miners started being properly paid. And there was a terrific lift. We did really believe that. I think the general feeling, Phil, the boss of South Wales Coalfield, Phil, but he thought, you know, we're going to have a new era for coal. And, Arabs would always live in tents and all that. But during that time, I was offered a chair in Manchester, another one in Liverpool. We went to West and we went to Liverpool. And we thought, oh, I'd be a hopeless professor in the head of Parliament. I can't anything bigger than that, you know, so. And I wouldn't be able to do research anymore because I'd be having to run a department. And knowing how people talk about each other in departments,
So that's the end of the tape. I think it is very informative in terms of, you know, the key messages that I think Julian lived his life by, the importance of the personal commitment by a general practitioner to his community, but also to every individual patient within that community. And you need to care about them all. I think it tells us about the importance of integrity and honesty in the research method. And it is something that if one is committed to a scientific approach to medicine, which is part of medicine, there's an art to medicine as well, but commitment to the scientific approach, then one must have integrity and honesty. And I think as well, the commitment to training was a very strong message because, again, Julian, as well as doing everything else, also was a trainer for new GPs and indeed medical students as well. So I think the tape is very important because it shows how Julian actually lived his philosophy, but equally how it was a team effort with all the members of the practice team, with the community, and indeed his research team. So with that, I'll finish. And if there are any comments or questions, happy to try and field them. I see some people here that are probably much better equipped to answer some of the questions that might come up, but let's see what happens. Thank you, Carmen. Thanks, Andrew.
Thank you, Brian. Has anybody got any questions? We've got time for a few. Any questions? Just
interestingly, a very interesting talk, and one when one reflects on it, and I'm thinking about the intensive care law, the inverse care law, sorry, that, you know, I don't think things have changed much because with a lot of private health facilities now, many people are going to the private health rather than the national health. And obviously, which is a very sad situation for those people who aren't so well off financially or have other limitations in their lives. And so there's still a lot to be done in the present day from the very good practice that Dr. Julian had developed back in the valleys.
thank you, Lyndon. Is there a question? Anybody got a question for Brian? Okay, I'll hand you over to Andrew then to give the vote of thanks.
Thank you, Carmen. That's very kind. I won't take long, but just to say three things, really. First of all, what a pleasure it is to have Mary with us for this session. It's really nice to see you, Mary. And we know how much you also contributed to the efforts of Julian in Glyncorrwg. It's lovely to see people from Glyncorrwg as well. And I hope those who are not here will be able to watch the recording, which we're going to put up on YouTube after the end of this session. The second thing is really to thank Brian for his introduction, which is really an ideal introduction to Julian Tudor Hart and his life and work from somebody who knew him really well and in a professional context. And you were very self-effacing, Brian. If I'd asked a question, it would be, how did you find Julian and what was your role in Glyncorrwg and the Avon Valley? You usefully pointed out some of the things to watch for in the video. That the sound quality, I suspect, wasn't great in the original recording, and of course it lost more quality in the transmission. But I hope you were all able to catch quite a lot of it. What struck me very much was the honesty of Julian's narration of his time, and the other thing that struck me was how very different life was in the early days of the NHS, when, as you said, Brian, not everybody subscribed to its underlying principles. And also, what a huge amount of work someone like Julian as a GP could get through. 60 patients in 2 sessions each, and at-home visits for 25. That would, I'm sure, seem to the modern GP a huge amount of work. So there was a huge amount to think about in what he said. The third thing I just want to say is that we're very grateful to you, Brian, for taking part in this session and for giving us this introduction. And I suspect we ought to be coming back to you, Brian, to get your own recollections on another occasion. Diolch yn fawr. Thank you very much.
Thank you.
Thank you, Andrew. Can we just unmute for a minute? Unmute so we can give show Brian our appreciation of such an excellent start to these series of talks.
Yay, go Brian. Thank you, Brian.
Thank you very much.
Thank you very much. Thank you. Well, at the very beginning of Brian's talk, he showed you a slide that showed, we'll just give a very brief glimpse into the history and beginnings of the Royal Institution of South Wales. Any of you who are not members and are not aware of us, please access our website and maybe join to continue, so we get more support to continue putting together lectures like this. So before you sign out, please remember that our second lecture of this series is next Thursday, the 10th of February at the same time, 1 p.m, and will be given by Professor Graham Watt, whose talk is entitled A General Practitioner for the World. So also there will be a selection of items from Julian Hart's library on display in the South Wales Miners Library from today onwards to coincide with this series of talks. The South Wales Miners Library is currently open from Monday to Friday, 9 till 5, and Saturday, 10 till 4. An online version of this small exhibition will be available online in due course. I must say the Julian Hart Library is fascinating. I myself have accessed it during my research, and it really is well worth a visit and to have a browse through. So at the end of that, thank you again, Brian, and thank you.